Hello and welcome to Chapter 18. This chapter will be focused on altered elimination. This will focus on altered urinary elimination and altered bowel elimination. So first we'll talk about urine. And urine is produced by the kidneys. It is stored in the bladder and it is excreted by the urethra once it's produced. Your renal system helps with several different areas. It helps to regulate blood pressure. It helps regulate your body fluid volume and composition. It helps you to eliminate metabolic waste that the body no longer needs. It helps with synthesizing and releasing or activating hormones. And these are just slides that review your kidneys. You do have two kidneys and a bladder. Again, your kidneys help to produce the urine, whereas your bladder holds the urine, and then your urethra helps to excrete the urine once it's produced. When we talk about our alterations, more oftentimes than not, it has an alteration with urine removal. So the process of urine removal is that urine enters the ureters through the renal pelvis, and then it is propelled by those ureters into the bladder by peristalsis. And yes, you can have peristalsis in other organs besides the bowels. So yes, your ureters are propelling urine down into the bladder by peristalsis. And again, peristalsis is that slow progressive movement and processing of urine, in this case, into the bladder. So your bladder does fill and it does activate a stretch receptor. So your bladder is a certain size, and once it starts filling with urine, those stretch receptors are activated and your bladder starts stretching in response to filling with urine. The signal stimulates a contraction, which is more so controlled by the parasympathetic nervous system. And then you have relaxation of your internal and external urethral sphincters, which results in micturition. And when we talk about micturition, that is just the process of urination. Urine characteristics are that it's supposed to be yellow, clear. You may have a slight ammonia odor, but it shouldn't be severe. And normally, your volumes voided is 750 to 2,000 mLs a day. If you have dark urine, it may indicate dehydration. Cloudy urine may indicate some type of urinary tract infection. And if you have a more severe ammonia odor, that may lead to other urinary issues. With your urine analysis, this is how we evaluate our urine. So most of our urine, we look at the color and clarity of the urine. So this is a macroscopic or visual inspection. And then we do a biochemical check. So we'll use a urine dipstick. And what this does is that it helps us to look at the pH, the specific gravity, if there's glucose or ketones, protein, nitrites, and leukocytes in the urine. And then we have our microscopic analysis, which will look at crystals or squamous cells, white and red blood cells, and bacteria. Next, we'll talk about urinary elimination, the alterations and consequences. So these are the four areas that you can have altered urinary elimination, or this is the cause of your alterations in urinary issues. So you have altered mobility, which is where you have reduced contractions of hollow structures. So your renal tubules are not able to contract, your ureters are not contracting to help that peristalsis. As far as your consequences, you'll see stasis of your urine, and it'll keep your urine in the bladder ultimately, or in those kidneys. So you may have a risk for obstruction as a result of that. And as a result, you may also see altered reabsorption and secretion. You may have altered neuromuscular function, and this is just hinting back at that parasympathetic response. If you recall, the sympathetic response shunts the urinary area and the GI area. Well, when we talk about neuromuscular function with this is the parasympathetic response, and parasympathetic is more focused on relaxation and processing in the body. So your urination would fall in that area. So when we have altered neuromuscular function, you have the failure of your neural signals that help to produce those responses, or you may have an exaggerated neural response. You may have failure of appropriate muscle responses, and as far as the consequences, you may have limited or absent ability to eliminate urine. This ultimately presents itself as urinary retention or urinary incontinence. The next area is altered perfusion, and this is perfusion to the kidneys. And when we talk about perfusion, of course, that's the blood supply that is oxygenated to these organs. So you can have a focal, which is at one point, or global issue with this. And when we talk about focal, that is in one specific area, whereas global is affecting all the masses in there. And you do have consequences of ischemia and or infarction within your kidneys, and it does present itself as pain. You also may have altered patency, and this is an actual blockage or obstruction of your urinary structures. And the consequences is your blockage of urine flow. You may have dilation of your urinary structures that are proximal right before that obstruction. So, what that's saying is that if your ureter is obstructed, the area that happens before that ureter obstruction is dilated or it has stretched. The presentation is stasis of urine or urinary stasis, which could lead to give you a urinary tract infection, or you can have actual injury to your kidneys. When we discuss that injury to your kidneys, there are different phases that occur before it's scarred. So you have the early phase where your kidneys start to swell and you have edematous kidneys, and then you have where your parenchyma starts to scar. And when that scarring occurs, you're in a progressive phase. Your kidneys are starting to have altered function because of that scarring as a result of the edema in the early phase. And then after that, once the scarring has been there for so long and after so much exposure with that scarring, you do see some atrophy in the kidneys or lack of use in those cells. So when we have altered urinary elimination, it's just multifocal here. You have different areas that are affected. Again, the risk of getting an infection is highly increased. The risk of you damaging your kidneys through scarring is highly increased as a result of obstructions or patency issues, perfusion issues, motility issues. So it's very important that when your patients present with urinary stasis or urinary incontinence, things that are abnormal with the urinary function, that you address them, because you could see manifestations with your kidneys. And ultimately, you can develop chronic kidney disease or end stage renal disease or renal failure as a result of this. General manifestations of altered urinary elimination include distension, nausea, vomiting, fever, bleeding, pain. You have urinary stasis or urinary incontinence, urinary urgency or frequency, and you have altered volumes of excretion as well. There are different ways that you can diagnose renal and urinary issues, and they include intravenous pyelogram, which is an injection of radiocontrast dye to allow the visualization of your kidneys, ureters, and bladder. You may have a VCUG, or voiding cystourethrogram, and this is an X-ray examination of the bladder and urethra that is completed after your contrast dye is inserted into the bladder. You may have a renal angiogram, and this is a contrast dye that helps you view your renal arteries. Again, it's an angiogram, so you're looking at the perfusion and or obstruction of your renal arteries here. You may also have a renal ultrasound, and this is a non-invasive method, and it's an image of your renal structures that are produced with sound waves. So it helps you identify cysts and obstructions and or fluid collection. You can also look at renal artery flow with the ultrasound as well. Regarding your indications of altered urinary elimination, you do have things that occur in your urine when you have alterations. So all of these words are basically what they sound like. So you have proteinuria, where you have elevated proteins in your urine, and this can indicate renal failure or nephrotic syndrome. It can be preeclampsia. You can also have renal artery or vein thrombosis or tubulopathies with increased protein in your urine. You can also have glucosuria, and this is glucose in the urine, and this more oftentimes indicates a sort of diabetes. You have ketonuria, which is a byproduct. You see this more oftentimes in individuals with diabetes mellitus. And if they do have diabetes, there's a certain level that they have, but if there's elevated levels to a dangerous amount, you may see a condition called diabetic ketoacidosis, where you have a lot of ketones in the urine, and it's also a byproduct of starvation. You have hematuria, and this is blood in your urine, and this is normally indicating a UTI, tumor, kidney trauma. You may have tubular necrosis or glomerular damage within the kidneys. Pyuria is where you see pus in the urine, and it may indicate some sort of urinary tract infection. You may even have renal stones as a result of that, or acute glomerulonephritis. The next one is bacteria, and this all it indicates is that there is bacteria in your urine, and it may indicate an upper and lower UTI. As far as your diagnosis and treatment of urinary elimination, um, we diagnose with macro and microscopic urinalysis, and we talked a little bit about that in the previous slides. We'll also look at your GFR and creatinine clearance rate, and we'll also look at your BUN. Imaging studies again include that pyelogram or renal angiogram or renal ultrasound. As far as your treatment, you may have fluids that are administered, or you may have diuretics that are administered depending on the condition that is presented. As far as your stool elimination, this is an alteration in your stool pattern. So we're talking a lot about the GI system in your bowels. So when we talk about your GI system, again, this is your esophagus down to your stomach and even your intestines down to the rectum. So after the nutrients that you receive hits the intestines for processing, you do have large and small intestines, you have the colon. All of these are areas that could have alterations in your stool elimination process. So when you have elimination, again, there's that concept of peristalsis, and peristalsis is the progressive movement, segmental movement of masses. In this point, we talked about peristalsis in urine earlier, but now we're talking about peristalsis in the GI system, where you have this progressive movement of the bowel contents. And as peristalsis occurs, this is a form of fecal matter transport down to the rectum eventually for elimination. So as peristalsis happens, you do have water and electrolyte removal in order for the stool contents to form. Um, so you have to have peristalsis in order for you to eliminate your bowels. If it does not happen, then that's where you start seeing these alterations and backups within individuals. Here's a concept map on the voluntary control of defecation, and it is based off of a distended rectum, so that means the rectum is opening, and that sends an impulse to the sacral spinal cord, which heavily controls defecation, and that spinal cord sends a signal to your cerebral cortex, which causes defecation. So if you decide not to defecate where you're holding this in, you have your impulse that is inhibited, and that causes your anal sphincter or your rectum to constrict, causing you not to defecate. If you do decide to defecate, then that impulse is then stimulated, and that anal sphincter actually relaxes, allowing for defecation to occur. So here we have stool characteristics, and it's important to know how to characterize your stool because doctors are looking at different forms, colors, shapes, sizes, amounts in order to determine disease processes with your stool. So as you're documenting, make sure you look at the following things to characterize your stool. First and foremost, you want to look at how watery it is versus how solid it is. And if it's watery, it can attribute to unabsorbed nutrients or epithelial cells being left into the stool. It could indicate bile pigments, bacteria, fat, undigested foods, or inorganic solids. As it relates to color, that can tell different disease processes. Normally, the stool color should be about a brown color, and this is due to the sterylcobilin, or also known as bile pigment. But any variances outside of brown, such as a tan or maybe even a orange or a yellow color, can indicate disease processes. So make sure that you're always documenting the color as well as how solid or fluidy the stool is. Next, you want to look at volume, and of course, if individuals are having lots of bowel movement or a large volume of stool, you want to document how frequent and approximately how much. Sometimes, when an individual defecates in a brief, it's hard to tell about the volume, but at that point, you want to either say how many pads they're soaking through or how many briefs they're soaking through. That way, the physician or healthcare provider can get a understanding of how frequent these and how much the movements are. You also want to do texture, and texture can mean anything. It could be semi solid, moist, soft, and again, these would attribute to different disease patterns. As far as your elimination patterns, you want to document how frequent, and you want to document if the stool is hard, soft. You want to document if the pattern is consistent within a 24-hour period or if it's sporadic. Again, these pieces of information will help the physician understand if there's a different disease process going on. So, as you're documenting, just make sure you are as descriptive as possible and make sure you chart what you see, especially when it comes to GI bleeds. And I want to talk about GI bleeds specifically because GI bleeds can present in different colors. Sometimes you have a red stool from a GI bleed, which would indicate a lower GI bleed, whereas if it's brown or, well, black really, that indicates that there is blood in the stool, but it's an upper GI bleed. The reason why we document this is because, one, we want to know how frequent or how much is coming out of an individual with a GI bleed, because that could indicate some sort of hemorrhaging. Or in the reverse fashion, if they're not having enough bowel movements or you don't see any bowel movement at all despite giving individuals stool softeners and laxatives and things of that nature, it may indicate a small bowel obstruction or a large bowel obstruction. So you always want to document the elimination patterns as it relates to stool. So here is the concepts of altered bowel elimination, and as you can see, this actually mimics those of altered urinary elimination. We have altered motility, altered perfusion, altered patency. So the same concepts will apply instead of talking about the bladder, we're talking about the GI tract. So you do have altered motility in the GI tract, which would cause issues in your water and vitamin absorption. This could cause issues with your fluid electrolyte balance, and it also causes alterations in the storage time by which the bowel contents needs to process. You do run the risk of obstruction when you have motility issues, and ultimately the consequences do result in constipation or diarrhea. If you're not having a lot of time, or if that bowel contents is not spending a lot of time in your GI tract, you do see that present as diarrhea. Whereas if those bowel contents spend too much time in your GI tract, you'll see constipation. And again, if you get to the point of constipation, that does run into the risk for obstruction. As far as altered perfusion, you can have this in a global effect where it affects the whole GI tract, or you can have focal effects where it's just one section of it. And the consequences are ischemia and or infarction. When we talk about ischemia, this is actual tissue and tissue damage to the GI tract, and normally this presents itself as pain. Next, we have altered patency. And this is where you have an actual obstruction in the GI tract. And this can come in the form of tumors or impaction. And as far as our consequences, we see this present itself as distension. We can see impaired motility, which we talked about those alterations in motility earlier in this slide. And then you can have perforation, which is an actual hole inside of the GI tract. All of these would be considered altered bowel elimination issues and should be considered when you are dealing with a patient that has bowel issues. So here we have our general manifestations of bowel elimination. So you can have alterations in your stool volume and characteristics. And when we talk about characteristics, that's everything that we discussed: the color, the volume, the um, if it's soft or hard, things like that. Those would be the characteristics that are altered. You can note that if there's any bleeding, normally if it's dark stools, we call that melena. Or if we have an occult stool, and normally we do a sample with this, a hemoccult sample, it tells us if there's bleeding in the tract or not. Then you can look at pain, fever, anorexia, which means in this case that the individual is not eating. You have nausea and vomiting, and then you can have abdominal distension. As far as your diagnoses are concerned, of course, you have to have a history of physical, but again, they're definitely looking at those stool characteristics that are being documented by the nurse. They're also going to do radiographic testing, that's x rays, CT abdomens, KUBs, to get a picture of what's going on inside of the bowel. And then they may even do an invasive procedure called an endoscopy, and they have two different types. They have the sigmoidoscopy and the colonoscopy, which would help them go inside and visualize what's going on in the GI tract. And normally, the treatment of altered elimination is doing the underlying cause. This is a photo showing what appendicitis looks like and what a colon obstruction looks like. On the left here, we have appendicitis, and that is noted as a fecal mass that obstructs the appendix. And again, our appendix is not necessary to our GI tract. We actually, and most people do have this removed without any complications at all. But if that area were to get affected, we do see inflammation that causes pain and other signs and symptoms such as fever. Again, pain. Individual does not feel good because that is a blockage in that area. As far as the colon obstruction, we'll see the same thing. And in this particular case, it's an obstruction by a carcinoma. So this is a type of tumor that is located in the sigmoid colon here. And this is showing that the bowel is not able to eliminate because there's an actual physical obstruction between the exit or the anus in the rectum and the sigmoid colon. Either one of these can cause major issues in your patient, and you should be on the lookout for those signs and symptoms. But this is just two examples of what alterations in bowel elimination look like. This is an excellent concept map that describes the alterations in urinary and bowel elimination. As we've mentioned, that both urinary and bowel elimination can have alterations in motility, neuromuscular function, perfusion, and patency. Ultimately, it leads to an alteration in the volume of excretion with the body, whether it's more or less, which would lead to an altered fluid balance. And we've talked about what those alterations in fluid balance are. That can be hypovolemia or hypervolemia. Regardless, it's causing these issues in the body, which would lead to other body processes. So just make sure you understand this concept map and that this is dual for both bowel and urinary. And sometimes both of these happen in tandem. You can have urinary elimination problems and bowel elimination problems at the same time. And what that really leads to is a multifocal issue with fluid balance issues. Here are our concepts of altered elimination. At this point, you can pull out your syndrome disease cards and fill them out as we go over each one of these disease processes. So the first disease we'll talk about is urolithiasis, and this is the development of a kidney stone. You may have heard of kidney stones and how painful they are to get rid of. Well, this is the official term and name for a kidney stone, and normally it is considered a solid mass that is from a filtrate. Normally, the cause of urolithiasis or kidney stones is urinary stasis, or you have elevated levels of urinary salts, and this can consist of organic or inorganic acids. Normally, if you have these kidney stones, this is considered an obstruction, and if it travels far enough, it can obstruct your kidneys and cause other issues. Normally, when you have kidney stones, you want to get it treated as soon as possible due to the fact of obstruction and even the risk of infection due to the cutting of the insides of your kidneys and ureters. Clinical manifestations include pain, and they normally call this a colicky pain because there is a collection of urine in your ureter. It's not able to move past the kidney stones, so you do see a dissension of that ureter at that point. Normally, the colicky pain is acute, intermittent, radiating, or excruciating. You can also have non colicky pain, and this is considered distension of your ureter or renal calcices or pelvis, and it's normally characterized as a dull, deep, or varying intensity type of pain. So make sure you understand the difference between colicky pain and non colicky pain because it is a little bit different. Colicky pain is acute and intermittent, whereas non colicky pain is consistent, persistent, dull, deep, and it varies in intensity. As far as your diagnostic criteria, of course, you have to have a history and physical, and it's normally subjective findings. So, when we talk about subjective findings, those are our findings from our patient, and we're basing it off of what they're saying. We do a lot of imaging studies, and then we will do a urine analysis. And when the calculi or the stone comes out, we'll normally analyze that calculi to see what the composition is, and that'll further help progress treatment. As far as your treatment plan, you want to do pain control, and normally you supplement that with IV fluids. And that calculi or stone has to be removed. So, again, there's increased fluid intake by mouth, there's IV fluids that you give. You want to reduce the calculi size, so sometimes it has to be surgically removed. As far as prevention, you have to encourage a diet with foods that are low in calcium and other salts that would cause kidney stones. So, this is just describing the different types of kidney stones, and really what we're looking at is the size of the kidney stones and the location. You can have urate deposits in the renal parenchyma. You can have kidney stones in the renal pelvis, which is the large portion of where our urine is collected and then distributed into the ureter. You can have renal edema, and then you can have stones that are collecting in that renal pelvis. When they're large, they normally call them staghorn stones. And the reason why is because they're large and they fill the area of the renal pelvis. You can also have small calcium deposits or small kidney stones or very large kidney stones. So just take a look at this picture. Regardless, they are all forming in the renal parenchyma or in the renal pelvis. Urinary incontinence is also known as enuresis, and this is defined as the inability to voluntarily prevent the discharge of urine. So, this means that you have no control over your urinary bladder. As far as the causes, you can have impaired muscle contractions, altered neurotransmission, or you can have issues with hormonal stimulation, even mechanical factors dealing with your bladder. As far as clinical manifestations, there are different classifications of urinary incontinence. You have stress incontinence, which is more so directed towards an exertional stimulus. You have urge incontinence, which is also known as an overactive bladder. And what it does is that you have the overactivity of your detrusor muscle, which makes you go more frequently than not. That detrusor muscle controls how frequently you use the restroom. You can have overflow incontinence, which means that you have urine that exceeds your bladder capacity. And in this particular situation, you need a urinary catheter or a Foley catheter to help decompress that bladder. And then you can have something called functional incontinence, and then this is known as the inability to toilet independently. For your diagnostic criteria, you have to have a history of incontinence patterns and maybe triggers that are associated with those incontinence patterns. You have to have a physical examination, and they normally do specialized testing when it comes to your diagnoses. You may have a bladder scan to see how much urine you're holding in your bladder before decompression with a Foley or in and out catheter, and then they'll look at your post residual bladder volume and see how much you're retaining after that. They may also do something called urodynamic testing as well. As far as going internal, there's an invasive procedure called a cystoscopy, and this is where they actively go inside of your urinary bladder, and they see if there's any issues with the muscles or surrounding area, and then they'll be able to determine your diagnosis from that. As far as your treatment, they do bladder training and pelvic floor strengthening. These are also known as Kegel exercises. You can have pharmacologic treatments with anticholinergic medications. More specifically, these are alpha adrenergic medications. And you can also have surgical intervention, which would help relieve mechanical obstructions in the urinary area. The next disease we'll talk about is called polycystic kidney disease, or PKD, and this is considered the growth of fluid-filled cysts in your kidneys, and normally they develop bilaterally in the kidney, so they present in both the left and right kidney. Normally, when you see a cyst in the kidney, that means the functional tissue, or what would normally be working tissue in the kidneys, is replaced by these cysts. And what this ultimately results in is a reduced perfusion to that area. So we're not having oxygenated blood flow coming to that area, which can result in ischemia, as we've discussed before. And you can actually have tubular obstruction, which would cause urinary stasis. We have clinical manifestations such as enlarged kidneys, hypertension, flank pain, and that flank pain is normally in the back on the sides. You'll see altered fluid and electrolyte imbalances. You'll see renal stones. You can see diverticular disease in individuals with this. You'll see urinary tract infections, and they're not isolated urinary tract infections, they're frequent urinary tract infections. You have other organs that would get involved as the kidneys start to deteriorate. You have the liver, the pancreatic cysts, you have cardiac valvular disease, and cerebral aneurysms. As far as your diagnostic criteria, you have to have a family history of it. Of course, you have a history and physical with your presenting with your signs and symptoms. They'll give you genetic testing. You may present with hypertension for no other known cause. You have imaging studies that indicate cysts on the ultrasound, and these cysts can be intrarenal or extrarenal. And you'll also see laboratory confirmation of renal failure. So you'll see changes in the BUN and creatinine clearance and GFR. As far as treatment, you want to do pain control, you want to treat the infection and help control blood pressure, you want to promote renal function. You may see these individuals get dialysis or a renal transplant. This is a really good concept map describing polycystic kidney disease, and we discussed some of these concepts already. When you have damage in your kidneys due to these cysts, you'll see decreased renal blood flow. You'll also see tubular cell damage, and you'll also see glomerular damage. Ultimately, all of these lead to a decreased GFR, glomerular filtration rate, which indicates kidney disease. So make sure you understand that concept. Anytime there's damage to the kidneys, your BUN, creatinine, and GFR are affected. Of course, we cannot talk about urinary issues without talking about chronic renal failure or chronic kidney disease. You have 4 different stages. We won't necessarily go into that, but just know that there are 4 stages of renal failure, and then ultimately you do have end-stage renal disease. This condition can cause sodium and water imbalances because your kidneys are not filtering correctly. It causes potassium imbalances. More oftentimes than not, you'll see elevated potassium levels or hyperkalemia because the body is not able to excrete and move potassium the way that it needs to. You have alterations in your elimination of nitrogenous waste. You have erythropoietin production. You will see acid-base imbalances as well as the activation of vitamin D. Vitamin D regulates calcium very heavily. And you'll also see phosphate elimination, which also leads to hypocalcemia. Ultimately, if you have hypocalcemia, and I want to talk about this particular electrolyte imbalance, hypocalcemia is heavily regulated by vitamin D and phosphate. So when you have the elimination of phosphate, you do see lower levels of calcium, which triggers hyperparathyroidism because that parathyroid is sensing the levels of your calcium. So once it realizes that your calcium levels are low, it'll go into overdrive and overactivate that parathyroid to stimulate more calcium production, which ultimately leads to bone issues. In this case, you'll see osteodystrophies.
You'll also see skin disorders, gastrointestinal manifestations, neurological manifestations, and sexual dysfunction and chronic kidney disease. So just take a look at this concept map and make sure you understand all of these areas that renal failure can cause. The next disease process we'll talk about is diverticular disease, and this is noted as pressure on the large intestine walls that alters the structure and function. So, this is a physical abnormality. Normally, we see consequences from this, such as decreased bowel motility, we see bowel obstructions and impaired perfusion. Normally, the diverticulum wall along the colon is outpouching or stretched. You'll see clinical manifestations as abdominal pain, fever, nausea, and vomiting. As far as your diagnostics, you'll have a history and physical exam. Normally, you present also with abdominal tenderness and distension. They'll do a laboratory analysis. They may do a hemoccult blood stool. They'll look at your CBC to indicate if you have low hemoglobin and hematocrit, which ultimately indicates anemia, and they may even look at your white blood count to see if you have an infection. They'll do imaging studies of your GI tract more oftentimes than not, a CT abdomen with or without contrast, just to get a visualization of that diverticulum, and you may even see inflamed or ruptured diverticula. As far as the treatment, you do have to have dietary alterations and lifestyle alterations. You may have medications that help you form more stools, because normally individuals with this condition produce diarrhea. So you may have bulk forming laxatives, you may have antispasmodics. You want to control the infection with antibiotics and manage your pain symptoms. You want to give the individual bowel rest so that you'll present with NPO. You don't put more food in that area. And you may even see individuals get a colostomy in this area. That way they can, give that section of the bowel some rest. Or you may even see an ileostomy depending on how far up it is. And they may even surgically correct the perforated diverticula. And remember, perforation is where there are holes presented in that GI tract. Next, we have functional fecal incontinence, and we normally see this in children greater than 4 years old. So they will withhold feces for fear of pain of defecation. So normally, a child would feel like they have pain every time they defecate. So they will withhold their feces to prevent this from occurring. And there are developmental triggers for this, and it varies by child. You normally see this with the introduction of solid foods or with toilet training, and you may even see this as a response to anxiety for the start of school. So, you have two different types. You have retentive incontinence, which is where you see posturing, you see excessive stool retention, you have a history of hard or painful bowel movements, and even the presence of large fecal masses in the rectum because you don't want to defecate, um, and also a history of passing a large diameter stool. You have non retentive incontinence, where this is socially inappropriate. It's in the absence of a disease process and the absence of excessive stool fecal retention. Normally, this happens at least once per month in this individual, and the symptoms last for at least 2 months. And again, this is more of a stress response or an anxiety response rather than there being a more concrete disease process. As far as your diagnostic criteria, you have a history of fecal incontinence, you have diet history, there may be some emotional stress. And normally they will do a physical exam to rule out a disease process. As far as your treatment, you want to enforce behavioral management. You want to try and curb toilet refusal behavior. Maybe put them on a training schedule or toileting time to help promote defecation. You may give the child incentives, or you may prevent constipation overall with dietary changes. And you may have to do some counseling for those that are experiencing stress or anxiety. As always, make sure you review your chapter in the textbook, look at your guided learning questions, review your system disorder cards, case studies, and activities, review the clinical manifestations, diagnostics, treatment, and application. Make sure you quiz yourself and others, answer your questions in the textbook, and make sure you reach out to the instructor for clarification on your topics. Thank you, and I'll see you in class.